Thank you. Eric Crawl from Tampa, direct primary care family physician. I have the extreme pleasure and also tremendous challenge of helping you all solve the employer demand and supply challenge in the next 30 minutes. I know we have record numbers this year of people whose main interest is to answer that very question. So to that end, gentlemen, a few simple ground rules to make sure we cover everything. I've got 4 questions that I think really need to be answered. So we'll try and keep it to just under 2 minutes per answer so we can get through it all. So to get started, quickly, just introductions to let the audience understand what the scale of your companies are, perhaps number of employers, number of affiliates, and spread out through how many states.
Is this on? Okay. My name's Jeremy Smith. I'm in East Texas. I started a DPC practice called MyMD Select. We engaged employers very quickly and got started. And when we outgrew our region in East Texas, we had to start working with other affiliates. We started with small groups and started chasing the design of their actual health plan, not just being a service they could add to it, redesigning and customizing the health care plan. That was amazing. I've learned a lot. It's very complicated. We grew. We're about 70 plus employers, just over 10,000 lives that we're managing. And that was complicated enough that we had to create another entity called MyMD Connect. And what that company does is it does the administrative work of distributing patients to one solo doc DPCs out of residency to support them. Our mission is to support the employers, the patients, and the DPC docs because it's very difficult.
Clint?
Hello, everybody. My name is Clint Flanagan. I'm the founder and CEO of NextEra Healthcare, and we started this year as our 10th anniversary since we started thinking about this in 2009. We started with a couple of clinics in the Boulder County area. Those were fee-for-service clinics that we owned, and we launched, and from there, very early on, wanted to help small employers, and that turned into larger employers, but we knew in order to do that, we needed more clinics, and along that pathway, we asked some of our fee-for-service friends that own their own practices if they'd like to jump in with us. And again, this is many years ago when people were still confused, thinking DPC was concierge medicine. So they jumped in with us, and it's kind of chicken and egg. So in that case, we figured let's get docs first, and then hopefully employers will come to us. That has worked over time. We now have about 50-some clinics across 8 states. We take care of many employers, take care of thousands of covered lives. And if you look across our community at NextEra, many of those physicians own their own DPC practice. That's the high majority of them. There are a few that are fee-for-service physicians because there are places like Laramie, Wyoming, where there is no DPC, but there are really good primary care docs that own their practice. We're huge fans of small business. We're huge fans of getting care in a private setting, whether that's a private fee-for-service doctor, a private direct primary care doctor, which of course we prefer, or a private specialist. So that's what we've been doing. We're having a lot of fun at it, and look forward to the panel.
And now your former attending, Dr. Besmer.
This is true. So I'm Dr. Joel Besmer. I look at the slide there. It has Members MD beneath my name, and so that is my concierge medicine company. I am a concierge physician with a full concierge practice and a couple of partners in that business. But the business I'm here to talk about today is Strata Healthcare. Strata Healthcare, I am the medical director of. My wife is the CEO and runs the business and the owner. And we got into doing Strata Healthcare through concierge medicine. So I see, as I just talked about in the little video shoot I did for HintOS, about, this is really, direct primary care is really I see it as concierge medicine for the masses, right? I mean, what you do day in and day out in direct primary care is no different than what I do day in and day out in concierge medicine. And so in having that experience, the reason we started Strata Healthcare was Clint's a good friend of mine, and I saw what he was doing with NextEra in Colorado, and we wanted to do that in Nebraska. The problem was it was illegal. You could not do direct primary care in the state of Nebraska, so with Clint's help, we had to pass law first to make it legal, and since have started Strata. We're a little bit smaller than what these guys are. So right now we have about 25 affiliates, I believe, in the state of Nebraska. But we are just getting ready as of May 7th to run a 5-year pilot program with state employees, where the state employees will get to choose Strata Healthcare as their provider of direct primary care, linked with a high deductible health plan, and we're going to publish data then based upon what does that mean to the employer, really the taxpayers, how much money can we save them, what do the outcomes look like, and those kinds of things with the help of KPI Ninja that's here.
All right, great. So the three of you independently decided before it was called direct primary care that membership medicine was the answer to our future dilemma. What was it? So here the three of you are in your small practices succeeding. So what was it that you saw in the landscape of the healthcare system that made you say, we need to focus more on working with employers?
You know, the healthcare system is so broken. There are a lot of things you could go after to fix, but being in the primary care world and having a background in residency education, I think what came across to me first in this fix is what's broken is the relationship. The insurance companies and all the executives in healthcare and everything else have gotten in between us as providers and the patients. And concierge medicine is what taught me that this is what really matters, right? I mean, when all of a sudden I got to go do concierge medicine in an academic medical center is how I got started in that, and I got to go do that and concentrate on relationship, and I got to see how that changed the outcomes for my patients. It became very simple, and then I got to chat with Clint about what he was doing in Colorado and think about how could we start to apply this. And in all honesty, I think that a couple of things. You know, number one, this is much better for us as providers. But in the end, it's much better for the patients. And everybody wins. The insurance companies don't want to be involved in primary care anymore. They don't. They lose money. So the patients win, the doctors win, the insurance companies in the long run are going to win. It's great for everybody. It's a great solver of our healthcare problem. It's not the only solution. It's just a fabulous part of helping to fix a big problem.
So on the employer front, understanding we were in a small town in Colorado, a lot of our patients, many of them owned one company I'm thinking of was he was a HVAC, owned an HVAC company. Another gentleman owned a plumbing company, and again they were already our patients, so we pitched it to them. This is in the very early days. When they, at that time, and you still see this today, they didn't have any kind of coverage or care for their employees, but they could afford the $99 per month that we were charging, and where unemployment was 2.5% or so at the time, and they were looking to try to compete to keep good employees on and offer a little benefit to their electricians or HVAC technicians. So that was kind of one piece, and we were members of the chamber and did a lot of hustling and working to tell everybody what we were doing, and we just hope people signed on. Selfishly, I'm also a big craft beer fan, so I targeted Eric Walsh, the owner of Left Hand Brewing Company, and literally at a chamber meeting while we were picking up some appetizers and a beer, I pitched it to him, and 2 months later, Left Hand came on, and they've been on NextEra now for 6 or 7 years, so I'd like to say I supported his company for 10 years. I'm glad he can finally support mine. Again, we are huge fans of small business. And whether that small business is the electrician, whether it's the HVAC technicians, whether it's the guys that make craft beer, whether it's the doctor that owns his own practice, that's kind of in the fabric of America. And we wanted to support that on many fronts. We also knew that we could talk, but we're only limited to a certain amount of time. So we can talk and bring one person on, or we can talk and maybe bring a company of 30 on, right? And plus, a lot of the people that are on NextEra, they might not be able to afford it on their own, that $99 per month, but when their employer pays for it, it's a much different scenario. We have people that wait tables that make maybe $15 an hour. So the other big piece of that, too, is along that pathway, we knew that tens of millions of Americans get their benefit from their employer, which actually it's more of coverage than it is care these days, right? But they get that from their employer. So for us, it was... that was hitting us right in the face that we should target that, and truthfully, as we look back now on the chapters we've had, it's been a ton of fun because these are people in our community that we have tile our office. There are people in our community that we support their restaurant. So that small business connectivity in taking care of these employees has just been really a lot of fun and very, very rewarding on many levels.
That was a great answer. The reason I went after employers is because I identified them as victims in this system. We knew the doctors were victims, and we knew that the patients were victims, and DPC envelops the solution for that. But the guy paying for it is the employer, especially the small business owners. And only thing on the market at the time had no care involved with it. All of the options that they were being shown by their advisors were the same thing, and it was all trash. So we set out to develop the health plan that has care as its hub, as DPC, and it was extremely popular. And the beauty of it is, Clint mentioned, the guy that cannot afford his own DPC doctor is working for an employer, and if we can have that guy understand the value by aggregating data and showing him his return versus what else is on the market, it took off on its own. All we have to do is do quality care and show that data back to the employer, and word of mouth spreads this thing. So it helps everybody, but the employer is the victim.
Thank you. You guys are great panelists. That's easy. So since the focus of your growth has been not to employ docs or have brick and mortar practices, but mainly to achieve scale through affiliates, can you talk a little bit for those that might want to create some supply beyond their just local community? How does the local and the remote affiliate strategy work? How do you grow that?
Well, it works really well, and it's not that difficult. Because of the technology that's in this room and has brought us together today, we can use those platforms to connect DPC docs all over the place. If they at least have that in common, we can do the administration and distribution of lives and get this taken care of. What happens when you start chasing employers is you get word of mouth, bigger employers that have workers that are scattered beyond your region, and so you need everyone in the room. I need everyone in the room to help with these lives when we get them. So the other thing we wanted to do was to take those health designed plans and give them to the DPC docs. Let them be the channel to sell them. They have the relationship with employers, because there's not enough advisors out there that are well-minded and mind-missioned. There are very few, and you're gonna have to have the tools to go around those that are trying to obstruct what you're doing. And so that's how it works. I'm no interest in owning independent DPC docs. I think that's the piece that we need to support.
So all the affiliates in the early days of NextEra Healthcare were fee-for-service doctors that own their own practice. And having been in that world and owning our own fee-for-service practice, like we spoke a common language, and probably many of you in your room know that language, and we all had the scars and stripes and wounds on our body from that fee-for-service world. So we approached those colleagues and said, would you come on board? And then fortunately, over time, that dpcfrontier.com, courtesy of Phil Eskew, mapper, emerged, and you go on it today, and there are DPC docs everywhere. So the beauty of that, and this isn't rocket science on our end or intellectual property, we have a company of 1,500 employees in, let's just say, the state of Florida. They want NextEra Healthcare. We've got Dr. Krall in Tampa and Dr. Hernandez in Miami, but we need 10 more clinics. So what do? We go onto the DPC Frontier, we vet a little bit, and then we ask them if they'd like to come on board, and maybe 50 to 100 patients would come their way. And then we write them a check when the members select them as their doctor. And so it works out for that private DPC practice that maybe they have 200 or 300 members, and they got some side hustles, to bring revenue into their household. So this is a way for 50 to 100 members, maybe 150 members to come on board, and that doctor always has control of, if they get to a point of saying, like Dr. Keller in Denver did, he's like, gosh, I have a full panel, I don't need any more. So then we, to Jeremy's point, through software, we're able to make some quick clicks, and then patients aren't able to select him anymore. So I completely agree with Jeremy that the technology platforms, or the stack or so, I'm not a techie guy, but maybe it's called the stack, that you're using is really important. And for us, we've been using Hint for years, and we use Spruce a ton, and have just jumped on board with Elation, and we've got these groups here like KPI Ninja that it's just great, to have these groups in this space helping us. We spent a lot of time and money early on doing internal billing. And just save you the pain, like don't do that. You can if you want to, but talk to me after this talk. It was an easy decision when Zach and I were chatting. We switched over, and we should have done it a long time before then. So, do the things that, spend the time on the patient care. That's what your MD or your DO is for, right? And bring in these other smart people around us to help us because we need them.
Yeah, from a standpoint of acquiring affiliate practices and growing that footprint, in the way Strata Healthcare is set up, that becomes a critical part of it, because we literally had to decide, as Clint points out also, right? It is a chicken and egg phenomenon. If you want to go out there and get some of the bigger companies and do a study with your state and run a state pilot, you got to have a number of affiliates. And you got to have the affiliates before you go get the business, right? So that's why those people who say we can't do this through hybrid practices, I think are wrong. I think we have to be able to do this through hybrid practices. We can't all be pure DPC docs. I'd love for everybody to get there. I mean, that's a goal. I love that. But I think of Jeff Strohmeyer as the person who comes to my mind. And let me just tell you about recruiting Jeff. I met him with a bottle of wine. I walked up to his clinic on a Sunday evening. And he had just finished 48 hours of moonlighting at his hospital, where he was moonlighting as a hospitalist. And he moonlights on the weekends, and then he does urgent care in the evenings, all so he can continue to support his independent practice. Because these are the people that still are not owned by the system. The Jeffs out there that are doing all those things to support, I'm telling you, direct primary care is their answer. And so I go to Jeff and we have a conversation, and quite honestly, he gets tearful. Part of it's he's been working for 48 hours and hadn't had a lot of sleep, so he was a little emotional. But he gets tearful because he's like, this is what I've been looking for. I just want to practice again. I don't want to have to do all those other things. And so we can take a guy like Jeff Strohmeyer and start just dripping in direct primary care into his practice. And the more direct primary care he gets, the less fee-for-service he has to do, or initially what it did for Jeff was the less moonlighting he had to do. I mean, you got to get those kinds of things out of the way first, right? But then we're now to the point with Jeff where it's like, hey, I gotta start capping how many you guys are sending me, because I got to figure out now how I get more and more there. But we do not have a doc in our enterprise right now that does not want to be 100% DPC. But we also do not have a doc in our system right now that is 100% DPC and owned by us, because we are trying to go out and help save that part of primary care that is still independent. And this is the way to do it, is through the affiliation with them. It helps from all those perspectives also then of having the footprint to recruit the businesses and do those kinds of things.
Let me ask you this. How do you address the issue if you're going to go out and find an affiliate that is a hybrid or actually is fee-for-service? How do you make sure that that affiliate and their staff will be able to provide the accessibility and all the services that you're promising your client when they're really not a DPC doc?
Eric, that's a great question, and in all honesty, you have to have a good understanding of that. Lisa Fisher's going to be up here later today from Strata Healthcare, and I'm here to tell you, I've made a lot of hires in my life. I've done a lot of interviews. I ran a residency program for 13 years and interviewed over, probably 150 residents each year for 11 slots. So I've done a lot of hiring and a lot of interviews, but the best hire I've ever made is Lisa Fisher for operations. Because when you understand that part of it, what we do is we come into their clinic and we teach their staff. Hey, this is going to be different, and here's how it's going to be different. And you're going to love it eventually, but in the beginning, it's going to feel a little painful. But we've got to teach them how to do that, because they don't understand that in the beginning.
And is that a half a day or a full day? What is the boot camp?
You talking about the boot camp education?
Yeah.
So we actually put somebody in their office for days. I have a daughter, Morgan, who works for my company, and Morgan is our affiliate manager. And so Morgan goes inside the clinic and helps with how do you answer the phone? How do you greet the people at the front desk? I don't believe in waiting rooms for medicine. I've talked about that before. So if you're a direct primary care patient, I don't want them sitting in a waiting room. I want them taken directly back to the room. I want it to look different than all of that is sitting out there, because I want the people sitting in the waiting room to say, Well, why did that patient get to go directly through? What's going on with that? Right? So there are some ways in the design that you set it up from the beginning that, once again, at the beginning, the staff can think that's kind of painful. But as they do it, they start to love it because they also start to realize what kind of a difference this has made in Jeff Strohmeyer's life, right?
That's great. A really important question we have to get to. There are a lot of purists out there that say that direct primary care has to be a direct relationship with a patient directly, and that these employer relationships are going to erode what direct primary care is. So how do you balance the challenges of working with employers with the goals and intentions of why docs go into DPC in the first place?
So I think probably over 80% of our members come from employers. And then the other 20 or so percent are retail or consumer, we call it. And we're a little agnostic as to whether or not we're paid by the patient or whether we're paid by the employer. But I can tell you there's a lot of richness in having that relationship with the employer. We're able to do things, and we're now taking care of school districts that my kids go to school at. We're taking care of satellite companies, and you get into these companies and you start having these discussions about what they're spending and what they're paying for biometric screening, what they're paying for their pre-employment physicals, what they're doing for their workers' comp, and so you start to sit down with them and say, how can we help you even more than what's currently happening. For example, with your biometric screening. In the case of the school district we take care of, a company was charging them double what we charged them last year for 800 teachers to go through and staff to move through the biometric screening. So we did it with doctors and nurses. The other company didn't, number one. And number two, we charged them half and saved them about $20,000. So I know some DPCers may say you must only get paid by the patient. In our experience, which is years now, we found we're able to grow quicker, right? Because we can bring on an employer group of 2, 3, 4, 500. And again, I think you as a DPC physician, you're in a very unique position because you're not a benefits advisor, right? You're not. You're the doctor saying we're going to provide care for your company, and it's powerful on many, many, many levels. And so, I would highly encourage you to take a look at employers if you're not, and talk to any of us that are, and we'd be happy to help out.
It's a great question. Both of those last ones, I'm going to rip through my answers. I think good fences make good neighbors. In the employer market, if you have the health plan that designed, this is the rules, these are the fences, that's done once a year, and then it's over. Then the relationship truly is with the patient. It doesn't matter at that point that there's an employer because it is a direct relationship. There's a set of rules that was designed as a health plan that year, but that eliminates that. My heart says there's no reason an employer should have to do any of this. Patients should be able to, but that is the system we're in. And as far as necessity of scaling DPC, hybrids is one way to go. We took a different approach. When we're not present with a DPC doctor, through technology, we do completely virtual health plans for folks. And we have DPC docs that happen to be in that state run the entire DPC health plan and do everything they can do just purely virtual. So that's another necessity that came up, just like working with our colleagues that are hanging on in the market right now.
Clint, since you have multi-state affiliates, help those of us who really need to contact affiliates and grow. Take me through an example. What do you do when you're calling that DPC doc in a remote location to try and get them to take on, to be an affiliate? And you get that, that thanks, but no thanks, I'm good. I really want to grow my practice, but I went into this, for my patients only, and they're not willing to sign an agreement. How do you handle that situation to try, and encourage them to become an affiliate?
Artfully is how we do that a bit. I think what gives us leverage is we're physicians and we understand they're oftentimes the challenges that they have. We understand that you don't go from 0 to 500 members quickly. We understand that in some of those cases, one doc practices, they might not have the bandwidth to go out and market and do sales and do the legal side and the accounting side. They might not have not only the bandwidth, but the dollars to do that. We've got great people on our team that help with that. And legal is tremendously important. I don't work in that lane, but we have counsel there that helps us. So as I look back on it over years of doing this, our close rate's really high. I would say our close rate's probably over 90%. And in the end, we don't charge anything to become a NextEra affiliate. I don't think Strata does either. So there's like the risk up front is, from a financial standpoint, it's pretty small. And plus, what we like to say is we want to really help support you in your practice. It's our success if you have success, right? If you decide you want to open up another location or two in Tampa, right on, right? So it's really an environment where there aren't many losers there. And so I think for the affiliate physician, they're looking at it and they're weighing, do we want to come on board? The one thing we have in our contracts is we just ask that you not join a big entity like Paladino. Sorry for my Paladino friends in the crowd, but that's a bit of competition. And so that's about the only ask that we have. And we've found over time that we develop these robust relationships. We're supportive of one another. We have a once-a-month webinar where we're going through objectives and learning what everybody's doing in their different zip codes. So it's a fun kind of organic community.
Joel, I wanted to ask you specifically, you presented some great data last year with the Burton's Plumbing. Since you kind of have the governor's ear in Nebraska and you've been able to get 25 affiliates throughout the state, what do you think, compared to the other opportunities that the governor could use to meet the needs of the state employees, how is the direct primary care-based approach better, or what are the advantages over the other options he has?
That's a great question. The 30 seconds on Clint's is also, I just want to add, remember, we as primary care docs have been lied to and lied to and lied to. So if you're calling somebody to recruit them as affiliate, like a Jeff Strohmeyer, right, who presently is still in their other practice, just understand it's going to take time because they're not going to trust you. And that's honestly the beauty of having that relationship before. So then why would the governor choose direct primary care as the avenue to fix when there could be a lot of other things to go after? Is because he understands this is going to work. He knows this is going to work. It's a no-brainer. He's seen our data. He's lived inside of a direct primary care practice in a way. And he is a businessman. And he gets it. So he was hugely important in driving this through the legislature.
Yeah, I guess lastly, what role do you see each of your companies playing in the continued growth and progress of DPC in general?
We're going to play any role we can. One of the roles I'd love to play, and I continue to push people like Hint and Roamed and a number of others, and that is we've got to figure out how we all network together. Because it is a struggle, as Clint says, when you go to an employer group, and rather than being able to close that deal, you want to just be able to say, yeah, we've got your network covered.
Great answer.
Yeah, we're gonna keep doing what we're doing. We're gonna push the technologies that are here, and we'll push them hard. We don't want to build them, but we know what needs to happen. So we need the docs to reach out to us. That would make it a lot easier. Establish with us so we know where you're at. We'll come sell lives. We'll give you the tools to build your practices. That's what we want to do, and it doesn't cost you anything. So come on board.
All right, thank you. What an amazing panel, right on schedule. So. Be sure to tap these gentlemen later in the networking session. Thank you.